In this webinar, I shall be presenting and discussing about respiratory distress in neonates. I shall be focusing on identifying distress, how to understand the etiology, and we discuss the approach to management of such neonates to optimize their outcomes. Respiratory distress in neonates is defined as presence of at least two of the three clinical signs, which are tachypnea, defined as a rate greater than 60 per minute, retractions, which can be intercostal and or subcostal, and an expiratory grunt in a neonate who is less than 28 days of postnatal age. What is grunt? Grunt is a typical sound produced while the newborn attempts to breathe through a partially closed glottis and is widely believed to be an attempt by the newborn to maintain some amount of PEEP. You would know that PEEP is positive end expiratory pressure and is essential to maintain to a certain amount of functional residual capacity of the lungs. This busy slide tells you about the common etiologies for distress and certain clues which can help to understand the etiology. For example, a premature neonate with distress with history of inadequate antenatal steroids coverage or with a history of diabetes mellitus in the mother should make you think of hyoid membrane disease and better termed as respiratory distress syndrome as a likely etiology. Similarly, a term newborn with distress was born through meconium stain lichen and the chest X-ray is suggestive of diffuse atelectasis will make you think of meconium aspiration syndrome. Understanding the clues that point towards certain etiologies is important as many management steps depend on the etiologic possibilities. For example, risk factors for early on sepsis would help to initiate antibiotics timely, and the risk factors for RDS would help to decide surfactant administration. Similar to the previous slide, certain examination findings may also help to understand about the newborn better and plan the management well. A thorough chest and abdomen examination can help to diagnose CDH, it is called as congenital diaphragmatic hernia, which would have an hyperinflated chest and a scaphoid or flat looking abdomen due to the shift of the abdominal content to thorax. Need for oxygen assessment many a times help to differentiate the respiratory origin of pathology from non-respiratory conditions, which is well dealt in the next slide. Chest wall transillumination using cold light source would help to diagnose pneumothorax. Another way to understand that a systolic murmur in the tricuspid area along with a loud second order sound and a parasternal heave points towards pulmonary artery hypertension. So these are some clues in the examination which can help to understand the etiology better. Let's come to the monitoring. Monitoring of distress severity is vital to plan the management. Two simple scores are useful for the purpose. One is called Silverman-Anderson score. So this was derived to be used in preterm neonates with hyoid membrane disease. It is predominantly based on the assessment of retractions at various parts of the chest wall and hence is also called as retraction score. The pictorial describes how to look for each sign and how to grade the finding to get a summative score. A score of 4 and above would generally indicate need for respiratory support more than mere oxygen administration. An important point is to be noted actually here. The term upper chest does not mean above the nipple level as it is thought by many residents. It in fact indicates whether the upper chest moves in synchrony with the abdomen movement or not during inspiration. Similarly, lower chest is to look for retractions at the level of the mid and anterior axillary line in a supine lying neonate. Another score is the Downey score. The Downey score is different from Silverman in the sense that it can be applied across all gestations. Even though conventionally the score is also used to decide severity and management strategies according to the score, such decisions are waning slowly. Many nowadays would prefer to start early CPAP support even in the score range 1 to 3 if it is a preterm newborn, and the clinician believes that atelectasis is the underlying pathology irrespective of the etiology and severity, and scientific evidence does support this approach. Still, the severity scores as described above, both Silverman-Anderson score and Downey score play a very important role in understanding the illness severity. Now, to a large extent, common etiologies have certain age of onset and they have a understandable and predictable course. I will read only those important ones here. The usual causes with onset within 6 hours of life in a preterm newborn are RDS, older term is called high membrane disease. The second important cause is pneumonia, which is congenital. The third important cause is transient tachypnea of newborn. Aspiration syndromes contribute a lot in cases which present a little late, but generally in the first day of life. Healthcare infections, cardiac causes such as shock and drug-dependent heart diseases also play an important role, but later in life. Even though transient tachypnea of newborn is commonly believed as a problem in term newborns, contrary to the belief, preterm newborns more commonly are present with transient tachypnea of newborn. Now coming to the term newborns, other than transient tachypnea of newborn, aspiration syndromes figure as an important etiology for distress with onset usually in the first 24 hours of life. Aspiration syndromes include meconium, blood, and amniotic fluid aspiration syndrome, the former two being more severe in manifestation. Rest all remains almost similar as in preterm neonates. Certain clues may help us to differentiate various etiologies. In cases of respiratory origin of distress, tachypnea is usually associated with intercostal retractions and or an expiratory grunt. The retractions too are predominantly intercostal, even though upper airway problems can cause more of subcostal and suprasternal retractions and recessions. Auscultation may sometimes reveal crepitations indicating pulmonary parenchymal pathology. Prompt improvement in retractions and or grunt with recruitment interventions such as CPAP may indicate again a respiratory etiology. Administering supplemental oxygen, which is called by many as oxygen challenge, is a near foolproof method to differentiate various etiologies. Respiratory pathologies, more so with parenchymal pathologies, promptly respond to oxygen administration. Pulse saturation would increase at least by more than 20% from the baseline in such conditions, whereas absent to minimal increase in observed in a cyanotic heart disease with hypoxemia. Pulmonary vascular problems such as pulmonary artery hypertension show an intermediate increase following oxygen administration. These all help to differentiate these conditions. Chest X-ray plays a crucial role in diagnosis and management. So these are all the various chest X-rays. I took 4 common conditions to depict chest X-rays. So a chest X-ray with a low lung volume, reticulogranular shadows, air bronchogram, ground glass opacities, or whitened out lung points more towards RDS as a diagnosis. On the other hand, low lung volume would be defined as number of posterior intercostal spaces in the right hemithorax if less than 7, wide being on room air. If you find a normal to hyperinflated lungs, prominent minor interlobar fissure, a mild cardiomegaly, prominent hilar and pulmonary vascular markings, you should think about transient tachypnea of newborn as a possibility. In the same way, hyperinflation, which can be localized or generalized with areas of patchy atelectasis in a neonate born through meconium strain liquor, would indicate meconium aspiration syndrome, whereas a neonate who acutely worsens, especially while on a ventilator with pleural air and shift of mediastinum, would indicate pneumothorax. So these are some clues in chest X-rays. Now, gas exchange should also be assessed in a non-clinical manner. Various parameters and indices can be used for the purpose. The most commonly used index is the alveolar arterial oxygen gradient. Higher the gradient, less efficient is the transport of oxygen from alveoli to the artery at the level of lungs. I would not be describing the details of calculation here. However, one should remember to use a different barometric pressure for your city based on the height above sea level. Oxygenation index is another measure and probably a better measure actually of oxygenation in mechanically ventilated neonates. Generally, an OI of less than 10 indicates normal to mild respiratory failure, and more than 20 would become an indication for more specific management for hypoxemic respiratory failure. A more recent and a simpler index is oxygen saturation index, which replaces PaO2 with pulse saturation values. However, this index needs more studies and data before it can be used in routine clinical practice. Now let's go to the management of respiratory distress. In the initial management of the newborn with distress, it starts with an effective triaging to look at the sickness level and take steps accordingly. Remember the acronym TABCD, which indicates temperature, airway, breathing, circulation, and drugs, and follow that with airway along with oxygen. The next steps of management would differ based on gestational age. In general, preterm neonates would be started on CPAP as early as possible after birth due to the generic advantages offered by CPAP across all the disease processes. If you suspect RDS and the newborn has shown an inadequate response to CPAP, surfactant administration may be considered. This approach is coined as early delivery room CPAP with selective surfactant. Wherever indicated, you may start antibiotics in a rational manner. In cases where the efforts are poor or there are other indications as stated, intubation and mechanical ventilation may be initiated. If you look at the management of distress in a stepwise fashion, first step is to administer oxygen using short binasal prongs or a hood. While administering oxygen, one should take care that the saturations are monitored and the target saturations are adhered to in order to prevent morbidity such as return with prematurity. An example of a target saturation is given in this slide for your understanding. In special scenarios, we would be administering surfactant. This slide depicts the proposed algorithm for surfactant administration in various clinical scenarios. In nutshell, the most commonly followed and most evidence-based approach is early CPAP combined with selective surfactant administration approach as discussed earlier. Even though studies have shown that other than RDS, conditions like meconium aspiration and pneumonia also may benefit from surfactant administration, those are not standard indications and hence would not be discussed here. CPAP is the third and the most crucial step in the respiratory management of a preterm neonate. CPAP is nothing but application of continuous distending pressure throughout the respiratory cycle in a spontaneously breathing infant. The key point is that the infant should be spontaneously breathing or else this therapy is contraindicated. Common indications are any condition where the alveoli or the airway needs splinting. Examples are RDS, meconium aspiration syndrome, post-extubation and apnea prematurity. Once we decide to initiate CPAP, next step is to choose the right device and right interface. There are two types of CPAP delivery systems. One is continuous flow devices and second is a variable flow devices. The continuous flow devices, they are typical and the commoner ones, whereas the variable flow devices or other set of devices, they are less commonly used. The common bubbling CPAP and ventilator CPAP, they fall under the continuous flow devices. Detailed discussion beyond this point is not in the purview of the presentation and hence I shall move on to further interfaces. This slide and the next two slides show the common interface available in the market. A lot of studies have compared various patient interfaces. Based on the available scientific evidence, binasal prongs of a shorter length are the better interfaces for continuous flow CPAP delivery. Common prongs such as the Hudson prongs and the more recent Ram cannula fall in this category. When you start CPAP, you should start with the pressure of 5 centimeters of water and approximately 40 to 50% FiO2. Once you start CPAP, evaluate the neonate roughly after half an hour for adequacy of CPAP. This may be done by evaluating chest inflation, presence of grunt and retractions as well as the respiratory rate and a blood gas analysis. In the blood gas analysis, specifically look for the oxygenation, ventilation adequacy by looking at the PaCO2 and the pH and base deficit for acid-base status. You may increase the CPAP by 1 centimeter increment up to 8 to 10 centimeters of water in case of underinflation. Chest X-ray would help to understand underinflation better. Persistent or worsened retractions and or grunt and low oxygenation or pulse saturations below the target saturations are other conditions where you can increase CPAP by 1 centimeter increment. Many centers would prefer to intubate and mechanically ventilate at this point where the distress features persist despite a setting of 8 to 10 centimeters water pressure and 60 to 80% FiO2. A CPAP adequacy can be judged by the disappearance of grunt and intercostal retractions, a comfortable neonate with good chest excursions, reduction in the FiO2 requirement, normalization of PaO2 and PaCO2, and a normal lung expansion in a chest X-ray. Weaning off from CPAP is another important point. In general, the weaning should follow the same principles as when we went up. You would decrease the pressures by 1 centimeter water decrements and the FiO2 by 2 to 5% at any given time point. At 5 centimeters of water and less than 30% FiO2, and in the absence of grunt and retractions and apnea and bradycardia in the last 24 hours, one may consider removing the CPAP. Even though not in the purview of this topic, nasal interface of any kind can cause nasal injuries, and an appropriate and a very good nursing care is crucial for success in CPAP without local complications. So the important carry-home messages are as follows. Respiratory distress is the most common morbidity in neonates. RDS and transient tachypnea of newborn are the most common etiologies for distress in preterm neonates, and transient tachypnea and aspiration syndromes are the most common in term neonates. Simple scores like Silverman score and Downey score help in assessing the severity. Early CPAP is a mainstay of treatment, and a select group of preterm neonates would benefit from surfactant therapy also. Adequate nursing care is crucial for CPAP success, and target saturations to be maintained while giving oxygen to prevent complications like ROP. Hope you all have enjoyed the presentation and learned how to identify and manage respiratory distress in neonate. Thanks.